All right, and Happy New Year, everyone. Welcome to this year's first episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, we are here with Chief Medical Officer of the Centeno-Schultz Clinic, Dr. Chris Centeno. Happy New Year to you.
Happy New Year, Jason.
We might as well make the most of the new year, and that's why this episode is really talking all about your New Year's resolutions. And many of you are making them, but many of you are making them, and you may want to consider what New Year's resolutions that you can be making specifically to address any musculoskeletal condition pain that you're having. I know from my experience, this is one of those times where just about everybody at least gets the idea that they should be exercising more, they should be taking off some weight, they should be doing more things for themselves, etc. But pain is often the number one reason that kills New Year's resolutions. And that is because it is difficult to stay active, exercise, do those things, whether it's get a good night's sleep or walk more or be more active, if you are living and suffering with chronic pain. So, Dr. Centeno, we've got millions of people around the world saying, this is my year. This is the year I'm going to be healthier. Uh, let's talk about resolutions that will help them address their pain so that they can actually get rid of that number one inhibitor that will help them, or we should say that will prevent them from doing many of the things that they should be out there doing.
Yeah, obviously, Jason, as we get older, we all develop these little aches and pains, and usually it's that prevents us from getting involved in New Year's resolutions. Everyone has a New Year's resolution to get out there and do more, but usually there's something that prevents a lot of people from doing that. So it might be knee pain or hip pain or back pain or neck pain. Every time I do this, I get this pain. Now, some people just solve that or try to solve that using just take a Tylenol before you work out or take a Motrin before you work out. But that's really the worst possible thing you can do because then you get addicted to that stuff. And I've seen lots and lots of patients who can't work out or do any activity without it. And they never really figure out what's going on. So this is a great time to start thinking about how do I get that nagging problem fixed so I can do what I need to achieve my goals?
That's essential, and I want to make sure everybody's hearing. Before we get into the what to do, I want to make sure everybody's hearing the consequences of not making these changes. And you mentioned it. It's common. It's many times every pharmaceutical television commercial in some way will tell you, take two, call me in the morning, pop these, you'll be fine, and you can go about living your life. But what you said is essential because there are a lot of people that believe that I'll just make my aspirins or other pain relievers. They take them like a daily supplement. And there are dangers to doing that. Let's go a little bit deeper into what those dangers are so that people understand really the value, I'll even say the essential need to be able to make the changes we're going to talk about in just a few minutes. But what's the danger of sort of living on these painkiller medications?
Yeah, well, one of the big ones is cardiac side effects. I think most patients don't understand that probably the most dangerous drug that they can buy over the counter is Motrin or Advil. So if you take that stuff, you're going to triple your risk of dying from a sudden death, heart attack, or stroke. Now, if you're in your 20s, probably not a big deal because you've got a very small risk anyway. But as you get into your 50s, 60s, and 70s, and even 40s, all of those cardiac risks go up anyway, and you don't need any help. So as an example, I was just reading a new study on NFL players who are in retirement. And many of them got hooked on this concept of taking Motrin or other non-steroidal anti-inflammatory drugs when they were adolescents coming up in the football chain of command, if you will. And then by the time they're retired, they take this stuff to function. And the ones that take it have much higher cardiac risk factors than the ones that don't. So I think it's really important for us all to understand that at the end of the day, you can't just take this stuff without risk. In addition, there's the risk of severe stomach ulcers and bleeding. But the biggest one is cardiac side effects. And I think we all need to realize that if you're taking a medication like Motrin just to be able to work out or achieve your New Year's resolution, that's a serious problem.
All of these, I hope everybody's hearing that. That is a serious problem. You know, you'd be better off with the joint pain than you would the death from heart attack, obviously. um, but there's other issues as well. We know, for example, that these types of drugs are taxing on things like the kidneys, the liver, and other body parts. These are toxins that the body has to process. But from a more functional, not necessarily organic risk, but a more functional risk, one of the things we just want to remind everybody about taking painkillers is that pain means to pay attention inside now. And when you basically sort of, suppress or turn off your body's own alarm system, letting you know, notifying you that something's not right inside, then what that opens you up to is running the risk of causing more damage. Meaning, if your knee hurts, then that's your body's way of saying, hey, you shouldn't be doing more things that are going to cause more trauma to the knee. However, if you take a painkiller and the pain goes away, then you are not able to respect what your body's telling you about your knee. And you'll often go out there and, in fact, cause more problems, create a greater injury to the knee. Doc, does that concern you? Do you see that as sort of being one of the more common reasons people have small injuries and end up with big injuries over time? Is this sort of false promise that the drugs are, quote, working? What they're inevitably doing is allowing the fire to progressively get worse over time. Does that logic make sense for people to understand?
Yeah, I think it's critical to realize that there's nothing about popping a Motrin or an Aleve that's going to solve your problem. Now, if you had a problem that was going to go away anyway within a few days, maybe that makes you feel better during that few days. But if you actually get to the point of having a more chronic problem, you're going to be causing more problems by taking this stuff. It's going to make you artificially feel like you can do these things when your body's telling you don't do those things. So again, if you've got a small problem that's going to go away in a few days, then taking this stuff probably isn't going to make a huge difference. But when you get into that world where you have to take this stuff to function, or you have to take this stuff just to get to your New Year's resolutions, that's a big problem because, as you said, you're risking further injury by not allowing your body to heal or not getting diagnosed what's wrong so that you can try to get it to heal.
Let's go into exactly that conversation now. So for those people that are suffering, they have New Year's resolutions. They recognize, okay, I'm not going to do the meds. If you are in pain and want to get checked, you should probably call the Centeno-Schultz office. But let's talk about New Year's resolutions that can help people reduce their risk of pain and help maybe even relieve pain altogether.
Yeah. So the
So
first, do you want
go
me to
ahead,
go,
Chris. Yeah,
Jason?
yeah, please.
Yeah, I think the first New Year's resolution is pretty simple, and that is if you've got chronic pain, stay off the juice, meaning stay off of stuff that's going to cause you more problems like Motrin and Advil and those sorts of drugs. The second thing would be, get it diagnosed. What's really going on? And regrettably, many times that means not going to an orthopedic surgeon, but going to someone who's similar to the doctors on the Regenix network, where they can say, aha, this is what's causing this problem. And then third is get that problem addressed and then pursue your New Year's resolution. And if you're lucky, and probably 7 out of 10 chance that you are, many times you can continue to work out while this thing is healing. So you don't really need to miss a lot in order to get these types of orthobiologic procedures where someone's injecting your own platelets or stem cells to try to heal something.
I hope people are hearing what we're saying here is that if this is your year to be more active, to, get out and just function better, and pain is what's stopping you, then the idea of living on medications in order to function is not the right idea. But in fact, seeing a specialist who can help you not just surgically repair it, because oftentimes that opens a whole Pandora's box to needing more surgeries and having more problems, rehabilitation, and so on. But really working with someone who understands how to help the body heal itself. So let's just say hi to a few people who are saying hi to us, and then let's get back to really helping people understand the distinction between treating a symptom with things like a medication and actually healing. What happens when the body's own stem cells, again, specifically is taken from the body for your body, what does the healing process look like differently than the I feel okay, suppress the symptom process? But before we go there, we've got our friend Tom Walsh saying Happy New Year, guys. And Tom, thanks for watching. Happy New Year to you as well. Kimberly, also a regular viewer. Happy New Year, gentlemen. Good morning, Kimberly, or good afternoon, wherever you are. Happy New Year to you as well. I got a question from somebody who submitted in advance, but Dr. Centeno, let's help people understand, what is that repair process really like, and why is it so much greater, so much better, such a greater benefit than just sort of fooling yourself to think, I can't feel it, so it's fine.
Yeah, well, you need inflammation to heal. Inflammation is how your body heals. So if you try to tamp down inflammation to make your pain better, then you're going to inhibit healing. It's really that simple. So that's why anti-inflammatory drugs are never a great solution if you're trying to get some chronic thing to heal, because they just suppress that process. Now, the other option would be to ramp up healing, and that would be some of the types of injections we're talking about, orthobiologic injection procedures that are precisely targeted to try to ramp up healing in certain areas.
And then let's get into more details. In fact, let me take this question and I'll ask you mine in just a moment. This was submitted in advance by Jerry Murphy. And Jerry's asking the question, does it make sense to get treated prophylactically? That's a great question. Or do you wait until you're broken down? And I guess I'll add, if so, how broken down? I think the question really is, and it's a great conversation, when is the right time to come on in, find out what's going on? I know we recommend booster shots in some cases. Help people understand the landscape. Is this a prophylactic procedure? Is it something you have to wait until there's some sort of symptom or sign that would go, hey, here's a reason to go get checked? How should people think about that?
Yeah, I think the way to think about that is that prophylactic care is just fine as long as we're doing it for the right reasons. So what I mean by that is that, let's say you have knee arthritis and we gave you a PRP shot and it was expected to last about a year, and right at around 11 months, you're starting to feel a little pain, then you'd want to get that repeated sooner rather than later. Or another type of prophylactic situation would be that you're starting to get some numbness down your arm. You're not quite sure what's going on there. You've had a chronic neck pain problem. Your doctor looks at it and says, you know what, there is an irritated nerve up there. Let's do a quick injection of some of your platelet growth factors around that nerve and get it calmed down before it becomes a big issue. Or, for instance, the outside of your knee starts to hurt. You're not quite sure what's going on. Again, it gets diagnosed early that while this may go away over the next month or two on its own, let's try to speed that along. So those kind of things I think are just fine in trying to be more proactive than reactive, because when people are reactive, they wait until things get really, really severe and bad, and then it gets harder to help without surgery.
Let's go through just so people really can understand, besides pain, what are some of the body's indicators, signs, maybe even other symptoms that are early signs that you as a doctor, as a professional would know if you were working with a family member or someone, or for yourself? Things like, restricted range of motion, perhaps even posture, or, popping or clicking, or things that are unstable just upon normal motions and movement. What are some of the sort of nuances? Obviously, when it hurts, people go, ouch. Again, they try to suppress it and hope it'll just go away, and usually it just comes back over time. But, since the question was about prophylaxis, what are some of the early signs we may notice in our bodies, waking up stiff or other things that may just be an early way for us to kind of start going, maybe something's going on here I need to pay attention to, as opposed to waiting for the screen.
Yeah, well, numbness and tingling is a big one.
Okay.
You shouldn't have numbness and tingling, so that's a big one to look out for. Other things, can include joints or the spine that pops and cracks a lot because it's got degenerative instability. Or, when a joint just feels unstable, you try to put some weight on the knee, try to do some things, and it kind of gives out. Or if after exercise, rather than that normal type of post-exercise soreness that you get when you haven't worked out in a while, that causes a pretty substantial flare-up that takes days to get better. Those are the kind of things to look for.
Those are exactly the kinds of things to look for. And if you're seeing some of those early signs, then what you want to do, as Dr. Centeno just mentioned, is you want to make sure you're talking to a doctor sooner rather than later. You want to make sure you're talking to the right type of doctor, not the type of doctor who's just going to write you prescription medication so you can suppress the symptom like we just talked about, and not the kind of doctor that's necessarily just going to rush to surgery as a sort of first approach to an issue. You want to, if you need surgery, you want to make sure you've exhausted as many conservative options before you go to that more extreme option altogether. So making an appointment with a qualified doctor who's going to focus on helping your body heal itself, as opposed to suppressing the symptom or providing more crisis type intervention too early on. And that would be the time to maybe reach out to the Centeno-Schultz clinic or someone on the REGENX network. You can find out if you have coverage, if you're lucky enough to be one of the 8 million people who are provided coverage for REGENX procedures by your employer. You can go to the website regenxcoverage.com and find out if your employer is covering your procedures. Speaking of drugs and all that, we're getting more and more questions, so let's connect with some people that are saying hi to us. Let's see. Kimberly followed up. She said, my mother had a pituitary tumor many years ago. She has required steroids on a daily basis for 20 years. She has severe osteoporosis and very little bone in her jaw. And medical docs use them so often for treatments, patients don't really understand the full long-term effects. You want to comment on that? I mean, it's exactly what we're talking about. A great example, Kimberly. Thank you for sharing. You want to share any other thoughts on that?
Yeah, being on long-term steroids dramatically hurts bone metabolism. As Kimberly's talking about, her mother has pretty severe osteoporosis now. In addition, those drugs also, in a dose-dependent fashion, increase the risk for a serious bone disease called osteonecrosis. So that means that the more of that stuff you take, the more likely you are to get a disease where your bone just kind of spontaneously turns to mush. So yeah, a lot of patients don't understand that those drugs have fairly serious side effects, and that doctors use that stuff kind of like water. I mean, they literally will just prescribe it for any particular reason if someone's got some chronic inflammation or even acute inflammation. So pretty dangerous drugs. They certainly can be very helpful if they're really, really needed. And if you look at the risk benefit, but there's a fairly substantial risk. So the benefit's got to be pretty clear.
I'm glad you connected those dots. And I guess that's the point I want to make sure people are hearing, is that, drugs can be very, very valuable under certain circumstances, but they always have a cost. Not sometimes, but always. There is a physiological, process or expense. Your body has to adapt to these medications. You mentioned it. It was said that she has osteoporosis and very little bone in her jaw. But you connected those dots that likely is potentially a side effect from the years and years and years of these medications. All medications have, we minimize them by calling them side effects. They're effects. That is the effect the drug has. And it's more obvious in some people than others, but all drugs have side effects. Is that true? Is there any miscommunication in that? That taking a medication for something will at some point tax your system in some particular way that may or may not be symptomatic, but by definition, it can be an issue at some point in the future. You're better off without them than with them in most cases for long-term use. Is that accurate?
Yeah, listen, I mean, there's no free lunch. Very few drugs don't have any side effects. So, every drug that you're on, you want to make sure you really need to be on it because at some point you're going to suffer some sort of side effect from that. The side effects might not be immediately noticeable, but they're all, robbing Peter to pay Paul, if you will. So, be very, very careful with that kind of stuff.
That's exactly. Let's keep going with questions in the time we have left. Damien. Damien says, Happy New Year. Happy New Year to you. He's asking the question, do you perform prolotherapy? What is it used for? And is ultrasound and or fluoroscopy used as a guide?
Yeah, Damien, we do perform prolotherapy. Prolotherapy, just so everybody knows, is injecting a substance that will cause a brief inflammatory healing response. So the idea is to try to initiate healing. Now, where does that work the best? It usually works the best in ligaments, sometimes in tendons, but mostly loose ligaments. So prolotherapy is a good way to tighten down loose ligaments. And yes, we use prolotherapy a reasonable amount in the office. Generally, we'll use ultrasound or x-ray guidance depending on which type of ligament we're trying to inject and where that ligament is. But prolotherapy is a good, inexpensive treatment which can help with ligament laxity.
There we go. Let's move on to Nancy, who asks, Dr. Centeno, I've learned so much from your articles and from my Regenexx doctor. Thank you for that, Nancy. A couple of weeks ago, I had gel injections in both knees from an ortho surgeon. He wanted to add cortisone and PRP from one vial of blood. I said no. Knowledge is power. Doc, what are your comments? What do people need to know from that message?
Yeah, well, lots of things. The good news is, knee gel injections, when done properly under ultrasound guidance, can be helpful in the knee. It's not a net negative like steroid. Now, adding cortisone in or high-dose corticosteroid injections is a dumb idea that's going to hurt the joint. So I'm very glad you said no, because you now have the power from watching all this stuff. And then doing PRP from a single vial of blood is also ridiculous. The kind of PRP that you would need in your knee, for instance, that we would inject at Regenexx is 14 times over your normal baseline amount. So for a simple single knee injection, that's going to be 14 tubes of blood in order to get that type of concentration. So PRP from a single tube of blood is really 1x concentration. It's not any more concentrated than in your blood. So you might as well just inject blood into the knee. So clearly the orthopedic surgeon had not a clue what he or she was talking about when it came to PRP.
It's fascinating to see and watch this trend in place. You see traditional surgeons now trying to sort of, I'll say, get on the orthobiologic bandwagon. People seem to be asking about it. And instead of really researching it and understanding sort of the revolutionary opportunity these orthobiologics play, they just want to sort of add it to what they're doing that in many cases just causes damage, makes things worse, and is more expensive, more time consuming to rehabilitate from. And according to the research, not nearly as effective. It's crazy to continue watching, but Nancy, what you said that I want to point out and thank you for is that you do have the power now because of the knowledge. And it is learning from doctors like Dr. Centeno and really taking the time to understand how your body works, what the dangers of what is very much the status quo and very common, but also very dangerous, what those issues are. It takes courage, time, effort, energy, but ultimately pays off when you've got the ability to make the right decisions because you know what to look for, you know what to ask. All right, Damien's got a follow-up question. I think it's because you mentioned OCD. He asks, do you treat OCD lesions and usually how?
Yeah, Damien, not with prolotherapy. So I don't think that prolotherapy would be helpful in treating an osteochondral defect. There's two things that fall into that OCD acronym. One would be osteochondral defect. The other would be osteochondritis dissecans. But Assuming it's an osteochondral defect, what that means is kind of like a pothole in the cartilage that extends down into the bone. Most common treatment we use for OCDs would either be a same-day bone marrow stem cell treatment or a culture expanded treatment like the kind that's offered down in Grand Cayman. Usually we'll start with a same-day treatment, try to get that to heal using that type of treatment. That would be an injection both into the joint, into the pothole, but also into the bone on the other side of the pothole as well, meaning it needs to be both a bone and a joint injection. Usually that's done under x-ray guidance, depending on where the pothole is located.
Great question, Damien. And if you've got questions, you can schedule an appointment at the Centeno-Schultz clinic for a more specific opportunity to talk to a doctor. And most importantly, do a review on you, your specific condition, your specific body, and really recommendations for you specifically. Everything we're doing here, obviously, is generally speaking. Nothing can be patient or person specific until you call the office and really have somebody have one of the expert doctors look at you, your imaging, your history, your concerns, and so on. So thank you, Damien, for your question. Quickly, let's get to our friend Doug. Doug Smith, Happy New Year. Happy New Year to you too, Doug. He says, had another knee MRI and ultrasound because of pain. The MRI showed complex meniscus tears and ultrasound showed LCL tear. I'm just not sure if I should get another treatment or go the surgery route now. He goes on to say, also, the ultrasound shows fluid in the knee. Doug, regular viewer, watching often. Doc, what do you suggest?
And did Doug mention what he was treated with?
MRI shows had another knee MRI and ultrasound because of pain. No, so it looks like he just had the MRI and ultrasound. It showed the MRI showed complex meniscus tears. Ultrasound showed LCL tear, and ultrasound shows also some fluid in the knee. So he's not gotten treatment from what I can tell at the moment, looking to figure out what's next, wondering if surgery is this a last resort? Is there a conservative option based on those findings, or does he really need to go? Basically, he's asking about, could a stem cell treatment be effective under these circumstances?
Yes, a stem cell treatment could be effective under those circumstances. Normally in people over 35, we don't care at all about meniscus tears, meaning that that's kind of an orthopedic fetish. And what I mean by fetish is that the research shows that meniscus tears in people over 35 have no real meaning unless they're causing the knee to have some sort of mechanical severe locking. Outside of that, there's no research that shows that surgically treating the meniscus tear does anything. In fact, we've got now 3 different large randomized controlled trials showing it's no better than doing nothing or just physical therapy. So I wouldn't let anyone operate on a meniscus tear, no matter how complex it looks or how scary the MRI report seems, because the research shows it doesn't do any good, it doesn't help. The research also shows that meniscus tears in people over 35 are as common as wrinkles and about as important. So it's probably more that LCL issue and the laxity in that LCL and maybe other issues, but unlikely to be the meniscus tear.
I'm going to take the liberty here and I think interpret what I believe he's saying, what Doug's saying here. If he's had a stem cell procedure in the past, would an additional or another stem cell procedure be effective? Maybe just obviously you can't say specifically for Doug per se, but in general, I know that there are some people that receive great relief and results in healing with one procedure. In other cases, depending on how severe it is, how complex it is, it may require several procedures. Would that be something for Doug to look into under this circumstance by chance?
Yeah, I think there's enough going on here where it would be good to get a telemedicine evaluation. So Doug, if you want to book one with me, I'm happy to take a look at it and see if it makes sense to do a second procedure and what the facts were about the first one.
There we go. And if you've got a few moments left, we got one more question from Petra, who's asking the question regarding the PICL procedure. Do autonomic issues diminish the success rate?
I don't think we know that yet, Petra. we have a good number of patients with autonomic issues who undergo the PICL procedure. A reasonable number of those people seem to respond well. But I think what you're bringing up is that when we started the PICL procedure, our focus was on traumatic upper cervical injury. And generally, those people have headaches, they've got instability symptoms, they may have disability related to their upper cervical traumatic instability. There is another group of patients out there who have loose ligaments or EDS, and many of those patients have autonomic problems. And then there's a crossover between those two groups. So we don't know yet if autonomic problems would cause a lesser outcome. It's not something I see clinically being a problem, but that data hasn't been reviewed yet.
There we go. So if Petra was interested in learning more about her procedure or more about her condition to find out if the PICL procedure might be appropriate, would a consult and an exam, I guess perhaps a telehealth consult, or if she's local, an in-person consult might be the next best step to really understand her specific circumstances. Is that accurate?
Yeah, a good thing to start with is telehealth. Usually patients aren't local. The only Regenexx clinic that offers this care is Centeno-Schultz Clinic in Colorado. So generally, that's a good place to start.
There we go. Petra, thank you for your question. And thank all of you for joining us on our first show of this year. We're excited. And as you can see, thank you very much for sharing. The more you stay with us, the more you learn about your body, how it works, how it's not intended to work, the more power you have to make the right decisions and the right choices for you this year and every year, for you and your family. Kimberly, thank you for your follow-up. Let's just make sure we say hi. And it says her follow-up with her mom. Kimberly's mom now lives with them in Mexico. Unfortunately, she can barely stand alone and unfortunately lost all her teeth long ago. It's hard to see. I'll take bone marrow harvesting and injections any day over general anesthesia and cutting. Kimberly, I think we both agree with you. And she closes by saying, cheers and have a great year. We will close by saying we agree. Cheers, have a great year as well. Thank you for joining us. And we're going to ask you for your help this year. We would like to build our audience significantly, not because we like more people to hear us speak, but because we know there are more people that need more help. And the way people find out about health in today's day and age, with all the cynicism and skepticism out there, is by people sharing what they know to be true with their friends and family. And if you follow our program and you follow what we're talking about here, and you know people who are suffering, then we're asking you to make the effort to share this with them. Invite them to ask questions, invite them to watch, invite them to subscribe, read the blog on a regular basis, and join us for our live shows where you can ask questions and we will answer them live. Doug, we appreciate everything as well. And again, what Doug's mentioning here is that we take the complicated science and we really simplify it into simple English, simple language, and I'd like to think even some common sense. It's easy to get blinded by the science, and that's our job. And that's really the power, is when you're able to sort of look at the science through a common sense lens and go, that makes sense to me, that doesn't make any sense to me, and you can make the right decisions for you. So Doug, Kimberly, Damien, thank you all for joining us. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. We appreciate it. We'll see you here Mondays on the Centeno-Schultz Facebook page, on Fridays at the Regenexx Facebook page. Until Friday, have a great week, everyone. Stay well. If you've got questions, if you've got pain, contact the Centeno-Schultz Clinic. Make your New Year's resolution taking care of your pain so that you can get out there, exercise, and take your health to the next level the way you deserve to have it. Thanks, everyone, for watching. We'll see you Friday. Until then, stay well and be kind.